All right. Question. And because we want people that are joining virtually to hear the questions, just give us a moment for someone to get over to you with a microphone. So we have a question right here, please.
Thank you so much. In situations where women would like to go smaller as part of their reconstruction, but told that a lot of times that two surgery. Can you speak to maybe why it has to be broken up into two surgeries with that lift and reduction first, or can it ever be combined into just the one?
Okay. Dr. Zong? Just grab the mic, will you?
Thank you. It's a complicated question because well, first of all, it depends on how large your current breasts are, how much of a reduction you would like to get. Also really depends on what type of reconstruction you're looking for. So are you looking for reconstruction using your own tissue as opposed to implants? So depending on those variables, the approach will be unique. But basically speaking, if you want to use your own tissue, then likely you can reduce at the same time, but also depends on if you want to keep your nipples or not and how much of a distance your nipple has to move to its new location, because it really has to do with blood supply. Because after they do the mastectomy, the blood supply to the nipple really is just random. And so we have to think about safety of, will the nipples live in the new place? What filler material, whether it's implant or your own tissue. So depending on that, then I think it becomes really like a shared decision making. These are the pros and cons associated with this versus these are the pros and cons associated with this method. And then I think together you formulate an individualized plan.
Thank you. Please.
I'm interested in having the tissue reconstruction, and I've spoken to a plastic surgeon, and I'm wondering if there are any plastic surgeons out there who can do that surgery without using surgical clips, which I've had really bad reactions to in the past.
When you say surgical clips, do you mean surgical clips that are put on the skin or surgical clips that are used inside your body with a surgical procedure that have been done?
Yeah, they're used inside the body to clip blood vessels, and they're really expensive to get out. And they cause a lot of pain when they're attached to nerves.
Okay, well, I'm going to ask our resident microsurgery expert, Dr. Lipa, to speak to that.
So at least in my hands, I would say I use surgical clips. So they're usually titanium. Those ones are usually non-reactive. So again, I haven't heard of that being the case with non-reactive. I did hear you saying something about nerve. So if a nerve, if it's caught up in scar tissue or caught with a surgical clip, then that may not be necessarily that the person's having a reaction to the clip, as it may be that there's been a neuroma, and then there are ways to treat neuromas as well. And so it's hard to tell sort of the difference with that, but it's pretty much it's a safety issue now that surgical clips for controlling those big blood vessels that we need to, divide, and then all the side branches, that it's actually something that makes the surgery safe.
Is there a question from the virtual audience that someone was keeping track of, Ishan?
Could you shed some more information about breast implant illness and what its incidence has been in your practice?
Yeah, that's a great question. And it's an incredibly complicated question because when we try to talk about... Sure. So the question was, could you talk a little bit about breast implant illness? What is that? What do we need to know about it? Very common question, something that's discussed with everybody when we talk about breast implants. And to be fair, probably something that takes many minutes, not just a couple minutes, to be able to discuss and give it appropriate worthiness. But does somebody here want to give a little brief 60-second blurb on what you might say about breast implant illness? Or I'm happy to say a word or two if no one's jumping up. Essentially, I think when we really look at it, breast implants are devices and they're put into people's bodies. And we put things in people's bodies as surgeons all the time. Hip joints, knee joints, pacemakers, heart valves, knee joints, hip joints, you name it. Surgeons are putting medical devices in people's bodies all the time. Most of them are extremely well studied and have been used for a very long time. They're mostly very inert and very well accepted by the human body. There's been a concern over the years that breast implants might cause systemic general effects on a person's health. I'm not totally sure why it's been uniquely talked about with breast implants, because there's nothing overly unique about a breast implant as opposed to a testicular prosthesis or a penile prosthesis or many, many other things that are silicone related. But the one thing I can tell you is it's been studied extensively for 50 or 60 years. And I think the 30-second summary is most of the science shows that quite comfortably breast implants are put into people's bodies without a significant systemic effect or impact in terms of illness, connective tissue disorders, fibromyalgia, brain fog, chronic fatigue, etc. However, you certainly see patients who have had implants put in their body, and I'm not sure it's not for any implant, not just a breast implant, where they've had an implant and then they've had a series of a constellation of symptoms of a variety of medical problems that maybe are unexplainable or haven't been diagnosed. And I personally think that it's possible that there is a very small subset of people whose immune systems just react to a foreign material in their body in a uniquely different way than many other people's might. And that the removal of that foreign body from that body might make them feel much better. And whether that's a physical improvement, a psychological improvement, both, doesn't really matter. An improvement is an improvement. And so the answer is, I think it's extremely rare. It's been studied extensively, but I think that systemic impacts from an implant in the body are real and probably exist in a small percentage of people. Let me ask our three patients that, having shared those inspirational stories, if you had one piece of advice to a patient that's starting this journey, either the journey of reconstruction or the journey of dealing with a diagnosis of breast cancer or dealing with the news of having a genetic mutation that puts them at high risk. I know it's hard, one piece, but if you had one, maybe could you share that?
Mine would be that it feels so huge in the moment, just unimaginably huge, but that it really won't feel huge when you're through it. It'll feel like much smaller and in the past. That's my one takeaway. I wish I had been told that. I probably was told that, but maybe you need to experience it in order to really believe it.
Andrea?
My takeaway is that every experience is unique, and everybody has to, or every patient has to live, but has to also share it with the surgeon that has, and go ahead with what you believe. And that's a unique experience that you have. And if it doesn't work in one way, it's going to work in another way. But it's important to consider every factors that Dr. Brown has mentioned. It's not only one, it's many. Yeah.
Healing is not linear. It is a journey, and it is fits and starts. It goes back 2 paces, it goes forward. And the patience is something that, I don't know if that's why we're called patients, but you certainly need a lot of it. And that will be, just forgive yourself when you are in the bad place, if you're unhappy, if you're asking a lot of questions and you're wondering if you're just being too much. You're not. And it's not linear. So be patient with yourself. Be patient with others. Go with kindness.
Question from the audience, please.
Hello. My question is about fat grafting. You've discussed in a lot of the presentations that's often supplemental to kind of help add a bit more contour or a little bit evening. I believe I also heard that it's typically taken from the abdomen. Is there a reason it should just be from the abdomen? Is it a safety issue, or is there other parts of the body that it's relevant for too?
Thank you. Dr. Manning?
I'll take the question because I mentioned the abdomen. I like the abdomen just because a lot of women come in with an area on the abdomen that's a great donor site and the fat takes really well. But no, there are other areas for sure as well. Actually, some of the areas we talk about when we do the autologous reconstruction are using your own tissue. If it's not enough to make a breast, sometimes it's enough fat to bore out actually fat graft. So the inner thigh, the back of the buttock area, the flank area, or the love handles, and the abdomen tend to be big go-tos, and all of that fat tends to take really well.
And can you address what you tell patients, or if a patient asks you about, is there a concern or a risk related to my breast cancer or breast cancer recurrence or screening if you fat graft into an area?
Yeah, it's a really fair question. So with regards to fat grafting, as far as all the research and everything we know about fat grafting, it's very safe and it's not going to potentiate any new cancers forming, and it's not going to increase the risk of recurrence. However, it can cause little nodules that can form, and sometimes, especially if somebody's been through breast cancer and has felt a lump, that can be a little bit challenging to experience. So I do prepare patients for that. It's something called fat necrosis. It's sometimes a little bit of the fat can die off and not get enough blood supply. So it's something to consider. And then depending on the cancer treatment, the original presentation, sometimes we do wait. Sometimes we wait at least a year, let the breast settle down, and then consider fat grafting later for patients, just so that they really feel they've hit that 1 year mark or maybe even that 2 year mark where they've been cancer free. And now they can handle some more surgeries and not worry so much about those little nodules.
At the back, please. Or anyone who has a mic.
Oh, I have one. I had a single mastectomy done. Sorry, I had a single mastectomy done, and my question would be like, would I be able to? I'm not sure if I'd be able to get that done with a DIEP flap. I'm thinking maybe it's the breast implant. If I'd be able to go bigger, but then I would have to do this side too, right? Because I'm always like, from what I was hearing is like there's a lot of people like from what I was hearing there's reduction, but like if I wanted to go bigger, because I've always been almost basically flat.
Yes.
So now I'm like extra flat on one side.
So those are common questions. And obviously we can't talk about specific patients and specific problems, but the question about, do I have enough tissue? What can I do about the opposite side? If I maybe want a bit of an augmentation of my opposite breast and then build a bigger breast with my reconstruction, I think that's kind of the genesis of what you're asking.
Yes.
So Dr. Maltaji, do you want to say a few words about that?
Yes, definitely possible. Sometimes if you want only to use your own tissue, we're limited more by what you have to offer as a donor. So if you want to use your abdomen only and you're reconstructing one breast, the chances are you can get a fair amount of volume, but then when you go to 2, you're splitting that in half, so it's a little bit less. There is an option to use an implant in addition to your own tissue. I've done that at the same time, so doing a free flap with an implant. That does carry some higher risks for failure just because you're moving those little blood vessels and now you're putting a foreign body next to them too. It can also be harder to control the shape, but you can do the reconstruction with your own tissue and then introduce an implant at a later time to change the projection or the size as well. And the same is true for balancing, because usually you're balancing both the shape and the size. But the long story short is, yes, it is possible to be bigger, but it may not be possible to do that just with your own tissue.
Okay, thank you.
Question at the back.
Hi, I was wondering if the risk of lymphedema is about similar with a prophylactic mastectomy as it would be for a mastectomy with disease?
That's a great question. So, because generally with prophylactic, your general surgeon is not offering a sentinel lymph node biopsy or a dissection or radiation, the risk would be much lower because there is an operation happening in that axilla. So, there's not really as much of a chance of cutting a lymphatic channel or damaging it with radiation.
Ishan?
Can a lymph node transfer be done during DF? And if so, what can I do if it's not offered by my province?
Okay, the question was, can a lymph node transfer be done while having reconstruction or a DF flap? And what do I do if it's not offered in my local area or in my province?
So there is some description of trying to incorporate the lymph nodes that are near where you take the DF tissue. I think it's not an operation I would offer just because there's always a risk, theoretical or practical, that when you're taking lymph nodes from other superficial places in the body, you could cause secondary lymphedema at the donor site. And then that's a devastating complication, which is why my preferred donor site for doing a free lymph node transfer is from inside the abdomen, where we have a robust supply of those lymph nodes and no risk of that secondary lymphedema complication. That being said, that now becomes 2 free tissue transfers, and I don't think it's necessarily safe or reasonable to want to do those both at the same time, especially when they can't be staged safely. So I would say if you require a free lymph node transfer, it would be therapeutic and at a second stage separately for treatment.
Thank you. We can do 1 or 2 more questions, and then the good news is the speakers will all stay around for a while, and we'll try to answer everybody's questions as best we can. Please.
Hi, so if deciding to do like the fabulous Andrea and stay flat, is it possible to, because I'm quite concave, my sternum sticks out quite a bit, can you get it filled in a little bit and still stay flat so you're not so concave?
Right, well, that's a very wonderful question. Dr. Zong?
That's a great question because I think most patients don't appreciate that when you have to have a mastectomy, your chest contour actually becomes concave. It doesn't just lay flat. So there are technical things that we can do. We call them like dermal flaps, or we can borrow tissue in adjacent areas and still have it be oncologically safe, but try to contour where we anticipate there may be concavity. So there are these things that we can do and the way we lay these flaps to try to smooth things out. But I do have to warn patients that what you see on the table sometimes is not how patients go on to heal. So the best you can, you smooth it out. There can be extra redundant tissue in places that you didn't anticipate and concavity in other places. I personally don't do fat grafting at the same time as doing mastectomy. I think it can be done in some places and maybe more in American centers. I don't do it. I do the best we can. And in a delayed fashion, I think fat grafting can be used.
Dr. Lipa, anything to add? No.
I would agree with that. The other thing sometimes too that women choose to do is if they've had a reconstruction, but then decide that they don't want the implant reconstruction any longer, kind of like how we had heard, then sometimes again we can use some of that extra tissue that was there and sort of tuck it under. So yeah, there are various different ways, but I agree. I think fat grafting is very powerful, but again at a second stage. So after, when if there are still contours to address, nothing else.
One other thought that's worth just mentioning is, remember, all mastectomies are different and everybody's anatomy is different. And a mastectomy is to remove the breast tissue, but not to remove the fat that doesn't have to be removed. And most breast surgeons are very conscious about trying to leave all the fat that you can. But in some circumstances, you can really work hard to leave thicker, more noticeable amounts of fat underneath the skin and still safely remove the breast tissue. And that might help somebody who's prone to having a concavity based on their underlying chest anatomy. I think we can do one last question, please.
Okay, great. I'm curious about nerve grafting or nerve preservation techniques. Do we have anything available in Canada?
Great. Who would like to address that? Hi.
Sure, I can speak to that. So I did my additional fellowship training in the US where we do nerve graft for basically every patient. To do that, we preserve a little bit of the nerve on the flap and a little bit of the nerve on the chest, and then you have to bridge that really long gap. So generally to do that, it requires a 7-centimeter allograft, which is a decellularized cadaveric nerve that allows basically a conduit for that nerve from your chest that's living to grow into that nerve that's been cut onto the flap. Now, the same thing can also be done at the time of mastectomy for mastectomy skin flaps. And in that case, we generally do 2, one to the chest wall, like one to the lateral breast envelope, and one to the nipple areolar complex. But you still have that same issue of the gap. And that gap requires the nerve graft, which is about anywhere between $10,000 to $20,000 per graft, and that's not currently covered in Canada. So it's not that we don't have the ability to do the operation, we don't have access to that nerve graft under OHIP to provide that procedure. So I know, if I may say, Dr. Zong is working very hard on finding a creative solution for that for us, but we are a little ways away from that being a insured operation.
I was also told before I had the surgery, you will not have any sensation. And then after the surgery, they were like, so do you have sensation yet? And I was like, wait, but you said, and they said, no, we just say that so that you don't have your expectations, but the nerves do grow. And they grow a little bit every week. And I have experienced, like, at first it was so numb, it was very strange. And it was like, I couldn't feel if I was walking through my closet and clothes were touching me or whatever. But now, like, I can feel if something's touching me. And I have been told to expect that my own body will continue to grow the nerves.
Thank you all very much for answering those questions. I'm going to call up Elaine Goulburn to finish off this session. I do also want to say, though, that all of our speakers, and we have some senior fellows and residents that are all very knowledgeable in breast reconstruction, we will all stay here and up at the top and be happy to try to address and answer as many questions as comes our way, okay? Elaine?